Hello, everyone. I hope you're well and having a nice 2025. So, today I'm talking with Joanna Moncrieff. Joanna is Professor of Critical and Social Psychiatry at University College London and is also a consultant psychiatrist practicing in the NHS. Joanna has written a number of books within the field of critical psychiatry, which is a sort of reflexive enterprise that endeavors to reflect upon the ethical, um, the efficacy, ethics, and philosophy of psychiatry. And this conversation is predicated upon a 2022 review which Joanna conducted and subsequently led Joanna to write a book which is being released on the 16th of January. It's called Chemically Imbalanced: The Making and Unmaking of the Serotonin Myth. And that will be accessible on Amazon from the 16th of January. So I'll put a link in the description if you're interested. And in this book, and then which we talk about in this conversation, Joanna sort of tracks the origins of the serotonin hypothesis of depression, where it came from, um, essentially citing economic and social forces which were brought to bear upon it, and actually highlighting really the sort of perhaps paucity of scientific evidence for the hypothesis, um, or ostensible finding rather, that serotonin is causally implicated or even actually implicated in depression, which is really interesting. As Joanna talks about here, that in her findings from the 2022 review, not only is serotonin not causally have any causal role in depression, it doesn't appear to be even correlated with depression, which is controversial, and Joanna acknowledged that. So yeah, if you've ever wondered how is serotonin implicated in depression, or is it, this is an interesting conversation, I think. So yeah, enjoy and yeah. Yeah, so I guess what is the serotonin myth of depression? Yeah, and where does it
Yeah.
come from?
So the reason we did that review is because people have been saying in the psychiatric community for a long time that there isn't any evidence for the serotonin hypothesis of depression, even though it's been widely disseminated and is widely believed to be, or has been widely believed to be true by the vast majority of the general public. Most people thought that it had been established, not that this was a theory or a hypothesis, but that it had been established that there was a link between serotonin and depression. This was brought home to me when I realized that some very intelligent philosophers that I knew believed that this was the case. And I went and did a talk to the academic German department at UCL at one point, and again, all the people there in that department were really surprised when I suggested that actually this link had not been proven. They all thought it had been. So, so for several decades now, the public have been led to believe that there is a proven link between serotonin and depression, even though many people in the psychiatric establishment knew that actually this had not been demonstrated, this had not been proven. So I thought it was really important to get the evidence together and publish a paper that said this very clearly, that said this has not been proven. And so that's what we did. I got together a team, and we went through all the research in the main areas of research on serotonin and depression. And because there's been, a lot of research over the last few decades in this area, what we did was we looked at the systematic reviews and meta-analyses that have been done in each of these areas. So we looked at research that has brought together all the research in the different areas. Um, and got that research together, and then came to a conclusion based on that. And basically, I can summarize the findings very, very succinctly. We found that there was no convincing evidence for links between serotonin and depression in any of the areas of research that we looked at, and these are the main areas of research that have been done. Um, so so that paper came as a surprise to a lot of the general public, and I think it came as somewhat of an embarrassment to some sections of the psychiatric profession who tried at one and the same time to say, oh, no, no, it's not news, we knew that, and to say, oh, no, but serotonin is involved. There is evidence that it's involved after all. Um, so that was the sort of confused reaction from the profession. The the serotonin theory, although it's been around since the 1960s, the first chemical imbalance theory of depression was actually to do with noradrenaline, another brain chemical transmitter. But the serotonin, and that was um, created in the 1960s. But the serotonin theory came in soon after, and had been a popular theory in psychiatry, even though uh, it was never the case that there was any very strong evidence to support either the serotonin or the noradrenaline theory. But it really caught on among the general public from the 1990s onwards because of a very concerted publicity campaign by the pharmaceutical industry at the point of the release of the what we now call SSRI antidepressants. The first one of those, the first one that was widely used was Prozac, and then there were several well-known ones that came afterwards. Paxil or Seroxat, it's paroxetine. What else? Lustrol, sertraline, lots of these, and then the SNRIs came along, the selective noradrenaline and serotonin reuptake inhibitors, which are a little bit different chemically, but have been basically marketed in the same way. So it was pharmaceutical industry advertising that really persuaded people that a link between serotonin and depression had been established, and the psychiatric profession never really stepped in to correct that false impression that was being created by this pharmaceutical marketing. And so that's how we ended up with this situation that the majority of the population believed that there was an established link, whereas actually there was never any convincing scientific evidence to suggest that was the case.
Mm. Yes, which is extremely significant, and there's a number of implications from it. What it sounds like to me, if I'm hearing correctly and from reading it correctly, it's not just because I suppose traditionally within at least spheres of psychiatry, there it's sort of I guess what we might call sort of neural reductionism. This idea that depression is caused somehow by the primarily through some sort of aberrant condition of the neuronal architecture or connectivity, or or sort of a depletion in certain precursors of serotonin. So there's the causation, but it's the study, the review you did in 2022, actually that serotonergic disturbances cannot be significantly sort of identified as being implicated at all. So it's not just that there's no significant disturbance.
So that's a really good point. Um, we to establish causation, you would have to establish not only that there is a link between serotonin and depression, but that the abnormality of serotonin comes first and is somehow precipitating the low mood. And we found basically there wasn't even evidence of any link. So
Mm,
there was no evidence of an association or correlation, let alone a causal connection. Another research group did an interesting study a few years before ours. I think it was published in 2019,
mhm.
which looked at biological theories that
Mm.
where
Can you,
people
sorry, can you
have.
can you can you hear me?
I can hear you. You've gone fuzzy.
Yeah, that's fine. I'll
Have I gone fuzzy or?
no, no, you haven't. Bear with me. Um, that's better. Try that. Sorry.
Yeah, okay, that's right. Yes, I can see it again now. Um, so this group, led by someone called Kennis, can't remember their first name, I'm afraid, looked at research that has tried to establish whether a particular biological abnormality precedes the onset of depression and therefore might possibly be a causal factor. It's significant that they didn't include any research on serotonin in that paper because none of the research has adequately established that any abnormality of serotonin precedes the onset of low mood, or has even really been set up in a way that it could have revealed that sort of connection. But they looked at a number of different factors. They looked at some hormones, stress hormones, for example, thyroid hormones. They looked at some aspects of the gut and some metabolic factors and some others. And basically, they didn't find any evidence that any of these biological markers were associated in a causal way with depression, i.e., that there was an abnormality that preceded depression that could have been a causal process.
Yeah. And so then does all of this, in your mind, relate to this idea? I don't know if you could call it, yeah, I suppose framework or idea, which you've spoken about in previous books, which is, and I suppose this further confirms perhaps some of your hypotheses around what what psycho or sort of pharmaceutical uh, uh, therapeutic drugs are doing. To you, does this sort of further suggest that it's the disease state model versus the drug-based model? Would you
Yeah,
comment on that?
yeah. So I've um, for quite a few years now been putting across the idea that we are mistaken in our general understanding of what psychiatric drugs like antidepressants do. So the general conventional understanding is that these drugs work by reversing or targeting an underlying biological process that is a causal process that leads to the onset of the symptoms of depression or psychosis or anxiety or whatever state it is that we're concerned with. Um, and I've been saying that there's no evidence that any class of psychiatric drugs works in that way. Um, and so, of course, this this paper that showed that there was no evidence for links between serotonin and depression um, is further support for that view that the thesis that psychiatric drugs work by targeting an underlying abnormal biological state is not supported by evidence. Um, so that view is what I've called the disease-centered model of drug action. There is an alternative way that drugs can be thought of as acting. I don't want to say working. Sometimes we might think it's useful and that they work, but sometimes we might not. But as acting when they are given to people with mental health problems. So the drugs that we give to people, psychiatric drugs like antidepressants, drugs for anxiety, drugs for bipolar, drugs for schizophrenia, are all what we might call psychoactive substances. That is, and by that I mean drugs that change the normal state of the brain. They cross the blood-brain barrier and they change the normal state of the brain. If you give them to an animal, you will see changes in that animal's behavior. It might be quite subtle with some drugs or more obvious with other drugs. If you give them to a person who doesn't have a mental health problem, a normal volunteer, they will also experience changes in their mental state, in their level of consciousness, for example, maybe in their emotions and in various other aspects of their mental activity and sometimes of their behavior, their overt behavior as well. So these are what we might call mind-changing drugs. They change the normal state of the brain, the normal state of brain chemistry. And so what I've been saying is that what happens if you give these drugs to someone who has a mental health problem like depression or anxiety is you superimpose the changes that are produced by the drug onto the underlying problems. And we can see this most easily if we think of alcohol. Alcohol is another mind-changing drug, another psychoactive substance. We're all familiar with the sort of changes it produces. changes our emotional state, it changes our level of alertness, of arousal, um, our ability to think clearly. Um, and if someone who is depressed takes alcohol, they may temporarily come out of their depression or forget their depression.
Mm.
It may temporarily be obscured by the changes that are induced by alcohol. And we have a term for that in the English language. We talk about drowning your sorrows with alcohol. Um, I've also used the example of um, using alcohol for social anxiety disorder, because when I was training, we were taught that alcohol was a treatment for social anxiety disorder, that it helped people. And of course, that was not because it was correcting a chemical imbalance or an alcohol deficiency. It was because it the changes produced by alcohol include feelings of the lessening of social inhibitions. And so when that's superimposed onto someone who's very socially anxious, it can result in improvements in their ability to socialize. So that's the drug-centered model. And as far as antidepressants are concerned, the drug-centered model suggests that drugs like SSRIs have mind-changing effects may which may affect people who are in a low mood or who are anxious. Um, Now, what are these mind-changing effects? Well, the first thing to say is that we don't know much about them because we've been focused on that disease-centered model. And just to add about that, actually, because a lot of my critics say, oh, but we don't subscribe to the chemical imbalance model. We just give antidepressants because they work. But of course, we don't just give random chemicals out. We must have an underlying theory about what they're doing. And the underlying theory, if it's not that these drugs are changing one's normal mental state, the underlying theory must be that they are targeting some sort of underlying biological abnormality, whether that's a chemical imbalance or a failure of neural networks or
Mm.
connectivity, or whether it's, we don't know, it's just hypothetical. Um, so coming back to what antidepressants do, so we haven't paid much attention to this, but it does seem through research that I've done and other people have done that sorry, antidepressants like SSRIs in particular they're quite subtle drugs. They don't have very obvious mind-changing effects. They're not like alcohol. They're not particularly pleasant to take for a start. But it's important to realize that drugs can have psychoactive effects without being pleasant to take. They can cause changes that are generally unpleasant, like
Mm.
antipsychotics. Um, Anyway, the effects of drugs like SSRIs are quite subtle, but they do seem to involve some dampening of the emotions, or some numbing of the emotions, so that people describe being sort of disconnected from their emotions. Um, it's very, very common for people to say that they feel they can't cry when they're taking antidepressants. And of course, when people stop taking them, they often get a sort of rebound state of emotionality when they become very tearful, more tearful than usual because of the withdrawal effects. Um, so, uh, so so my thesis is that antidepressants affect people with depression partly through this emotional numbing effect, but also partly through placebo effects. And we know, although the defenders of antidepressants repeat endlessly that antidepressants work, what they actually mean when they say that is that they are very slightly superior to an inert placebo in a placebo-controlled trial. That's what they mean. But the difference between an inert placebo and an antidepressant is actually minuscule, uh, and
Really? Right,
and
right.
and doesn't get anywhere near the level that is generally considered to be a clinically relevant change. If you compare, um, so the most commonly used scale of depression symptoms, and of course there are lots of problems with measuring depression. I mean, that in itself is a questionable activity, but let's just put that aside for a minute. The most common measure of depression symptoms is something called the Hamilton scale. it has 54 points. And the difference between an antidepressant and a placebo in a placebo-controlled trial is 2 points. No
Wow.
research suggests that that 2 points is actually a meaningful difference. And
Mm,
if you measure changes using something called the Clinical Global Impression Scale, again, not a perfect scale at all, but that's a general rating made by doctors or assessors about people's level of improvement and change. A 2 point difference doesn't even register as any change at all, and you need to show an 8 point difference to be considered to be mildly improved. So
mm,
that suggests the difference between placebo and antidepressants is nowhere near even a mild difference, um,
yep.
even a mild degree of improvement. Um, and then add to that the fact that in these placebo-controlled trials, many people can detect whether they're taking the antidepressant or the placebo because of these subtle effects and because of other side effects like a dry mouth or nausea, feeling a
Mm,
bit groggy, a bit lethargic, which antidepressants also can cause, many of them. Um, and
mm,
and so actually many of these studies are not what we call double blind. We use a placebo to try and disguise what people are taking. But actually, it turns out that in many of these studies, people can work out whether they're on the antidepressant or the placebo. And it seems that people who guess they're on a placebo, sorry, guess they're on an antidepressant, even in a trial where the antidepressant doesn't is no better than a placebo, think they've done better. There seems to be a very strong expectancy effect from thinking that you've got an antidepressant. There's an interesting study actually with people with social anxiety disorder who were all given an active antidepressant, escitalopram. About half of them were told that they were getting a placebo, and half of them were told they were getting an active drug. And the half that were told they were getting the placebo had much worse outcomes than the half who were told they were getting the active drug.
mm,
Much less likely to show an improvement, and their scores didn't go up nearly as much. So, or didn't go down nearly as much, their anxiety scores.
yep.
So there's a high expectancy effect. So all that adds up to basically saying that antidepressants have not shown to work really convincingly to be any better than a placebo when you take into account the expectancy effects that are likely
Mm,
to be operating.
mm. Yeah. Yeah, really interesting. And I mean, there's two major points from what you just said there, which I'd like to pick up on, um, which is the placebo is really interesting because to me it's just tacit or further, how would you say? I don't know if evidence, possibly. I don't know if because evidence for a philosophical position is somewhat, well, but no, I do think we can draw an empirical to sort of inform our perhaps what we might call ontologies, which are important in psychiatry, because I think this idea of meaning, right? Meaning, because you know, the fact that a placebo has an impact in some way suggests that, ultimately our state of our mental state is somewhat, what if some might say it's solely as a function of meaning, that being it's not just the inputs we get, but how what our prior beliefs are, how we make sense out of that, which I think speaks to also this this other idea which I haven't read the book, but I know you go because I looked at the contents. I know in your new book you go on to speak about it, like, well, what is depression then? And what how can we actually respond to depression as a entity, or if we want to use that, I don't know if entity is quite right word, but as a phenomena, assuming we say there is this such a thing, or even if it's amorphous of depression, what actually might it be?
Yeah. So a couple of points to say to that. First of all, um, coming back to the chemical imbalance theory or the serotonin theory of depression, there's a bit of research that shows that people who believe in that actually do worse than people who don't, which seems to contradict the placebo effect in some ways. But actually, I think is consistent with it because I think what happens is that people who believe that that their depression is due to a brain chemical problem and that there's a drug out there to put it right, in the short term, being offered the drug will be a great boost. You know, they'll think, oh my goodness, fantastic. Here's a solution to my problems. In the long term, of course, because the drug doesn't work, because as I've just said, there's very little evidence that they're really helpful. Um, and if they are, it's probably a sort of a bit of an emotional numbing effect, which in the long term is probably not a very useful effect to have. Um, in the long term, actually, people end up often, I think, becoming even more depressed because they think, oh goodness,
Mm.
I've got this brain chemical problem. The drug hasn't worked. I'm biologically defective. What
Sure,
can I
sure, sure.
do? Yeah,
Yes, it reduces agency. It
it
reduces
reduces. Yeah,
agency.
yeah,
And also, and like you just saying there, for a lot of people where like their distress might be underpinned, if we're thinking possibly at least considering at least a psychological explanation or framing, it reaffirms maybe some core beliefs, like you just said, of like, I'm defective, but I'm hopeless, life's pointless.
yeah,
Yeah,
yeah. And I won't get better. Um,
yeah.
yeah, so I think it can be, I think can be very damaging, and 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 uh, and this is, I mean, this is why I wrote the book, really, because I think there has been this very damaging idea put across over the last few decades by the pharmaceutical industry, um, that that depression is a brain problem and that the answer is a biological one. Now,
Mm,
back in the 1980s and early 1990s, the majority of the population didn't think that. They thought that people got depressed because they got divorced, or because they had lost their job, or because they'd had a difficult childhood, or because they were lonely. When you asked people what causes depression, that's what they would tell you. And people were very hesitant about accepting the idea that depression was a brain problem, and very hesitant about the idea of treating it with chemicals, with drugs. People thought that giving drugs to people who were depressed would just numb them, just suppress their feelings. It wouldn't really address the real problems. And and those beliefs basically were systematically overridden by the pharmaceutical industry and the psychiatric profession in order to persuade people to take drugs, to believe that they had a brain problem, that a drug would put right. It was necessary for the pharmaceutical industry to run this campaign because prior to this, you'd had the scandal over the massive overprescribing and dependence potential of benzodiazepines. And so people had started to get worried about the idea of using psychoactive drugs to adjust their brain chemistry and alter their mood. And it's tragic, really, to look back and to think that actually ordinary people had a much better idea about the hazards of doing that than the medical profession or the medical industries that are meant to be there to help people. Um, People were concerned that antidepressants might be addictive, uh, by which they meant that they might be difficult to get off, like
mm,
benzodiazepines are difficult to get off. They didn't necessarily mean that they thought people would be hanging around street corners trying to buy antidepressants. They
mm,
meant that they could cause dependence, and of course, it turns out that they do, and that dependence is not a trivial thing. That some people get really severe withdrawal symptoms, find it very difficult to come off antidepressants. I've just done some research that shows that um, we interviewed people attending therapy services who had tried to come off their antidepressants. 38% had tried and felt they couldn't stop. So
wow,
38% of people who had had a try at stopping antidepressants couldn't do it, are basically stuck on drugs they don't want to be on.
mm. Yeah, which is sad. And also, it comes back to this point of reducing the sense of agency, but also like how kind of unfair it can be as well. If we consider depression, like you just said, as sort of implied, possibly, or at least all of this implies, is that, well, maybe then it's something to do with our circumstances, as being situated in, a world, particularly a social world. Um, and what happens, when that world doesn't sort of, help us meet our needs, and that sometimes we don't necessarily have, how would you say, influence over that, socioeconomic factors, childhood, and then to go to the person, yeah, sorry, mate, you just got to take a pill. That's it's quite harsh, really. Um, to
Yeah.
yeah, just stay, just to put, it's almost just like, yeah, it's, don't worry about all of that, just take a pill. Um, and
I think,
that's it.
but I think, but I think that's why the pill is attractive because, I think people do increasingly in today's world feel that they can't change their circumstances, you know,
Yes, good point.
that that actually modern life is difficult and it's, although we're all told that we can do fantastically and live like celebrities, in fact, in reality, we can't always get the
Mm,
we want or the salary we want or the house that we want,
yes,
or a house at
yes.
all or, anywhere to live at all. Um,
Yeah, and this is really, what makes me think of a point which I don't want to forget, sorry, is basically all of this is suggesting that there's a thing called depression, and depression is bad. But firstly, it's like defining depression is very difficult in of itself, like many psychiatric constructs, they're heterogeneous, both in their etiology, but also their present, how they manifest. And I'm pretty sure there's a paper done in the last 5, 10 years which looked at the different, sort of got a list of all the, it might have been using DSM or ICD criteria for depression, and this like using the minimum required for a diagnosis. I don't know what it is. I don't do diagnosis. Maybe it's 5, maybe it's 10. But anyway, and then they sampled, I don't know, 1,000 people, and they found something like 400 different ways in which depression can manifest itself, drawing from different symptoms. And then this comes back to a point I know you've made in your books before, is that we have to also consider depression is a sort of like a continuum, because it's not like, you can't what's carve nature at its joints, so to speak. It's a we're sort of imposing a taxonomy on it. And anyway, all of this to say is, how many depressions really are bad, or actually can they be? And I'm caveating it because I don't want to doubt that there are people out there who have really sort of deep depressions, which maybe they've looked to their social environments and they're struggling to make sense out of things, and they just feel like the medication, and maybe it does help. But how many people actually is, depression is actually a function of life, and that it perhaps sits is sending us a message as to actually, well, what isn't quite right, and what can I do about it? And my sense is that's somewhat what you talk about in the later parts of the book, maybe around like, well, what actually is depression, and what can it
yeah,
inform us? Yeah.
yeah. I mean, so the point I want to get across really is that I don't think we have any evidence, or good reason to think of depression as a medical disease, as a medical condition.
Mm,
I think it's better to think of depression as as an extreme form of a normal emotion. And our emotions are, by definition, reactions to our circumstances. Um, depression, anxiety, jealousy, hatred, love, all these things, that happiness, they're all responses to our circumstances, and not only responses to our circumstances, but responses that are influenced by all the other things that have happened to us in our lives and what makes us human. So by definition, they are individual. Um, although we can recognize a sort of general state of happiness, one person's, happiness is going to be different from another's, and each state of happiness is different because it's a response to a different set of circumstances by a different individual with a different history. Um, so that's how I think we need to understand depression as a response, as one of the ways in which human beings who are uniquely sensitive to the world around us, that's what it is to be an intelligent being. We are uniquely sensitive to the world around us, and one of the ways that we react to that world is through being sad and depressed, or anxious and fearful. Um, and and so if we want to understand depression, we need to understand what that state is a reaction to. for each individual who has it. And it makes no sense to think of it apart from that, to sort of think of it as a thing in itself, that you can, as if it's a liver that you can look at and you can measure, and you can say, oh yeah, you've got this much of it and you've got this much of it. That's just not a sensible way to think about it, I don't think at all.
Mm.
Instead, we need to say, it's a state of a whole human being, not a human body, not a human brain, a whole human being with our whole history and circumstances. And we need to say, what does it mean for this person? This person is reacting to something. Let's try and understand what that is, and how we can, and how that situation may be resolved.
Mm.
Some people, as you say, get severely depressed, in a way that, sometimes seems to be, I mean, I would say that there's usually some sort of trigger, but sometimes obviously it seems sort of quite out of proportion to the trigger. But, often the severe depression that you see in the elderly, for example, is a reaction to loss, to retirement, or to the death of a spouse, um, to loneliness and isolation. Um,
Mm.
And so I would say that even severe depression it still needs to be understood in that way. And just because
Sure.
it's severe doesn't mean it's any more likely to respond to antidepressants. Actually, the evidence suggests that antidepressants are probably even less helpful in people with severe depression. Severe depression responds in some cases to ECT, but when I say responds to that, ECT, I think we also need to understand in that drug-centered way as something that alters the normal state of the brain, and therefore the mind, and it temporarily puts people into an altered frame of mind so that they basically forget their depression until gradually it creeps up on them again. Um,
Yes.
so yeah, so I don't think severe depression is categorically different. Um, and I don't think it responds to medication. Um, and when I've been asked, how you therefore help someone with severe depression, what I would say is that we need to look after them until they get better, and that most people get better on their own.
Mm. Yeah, it's interesting actually, when you frame it like that. And because I suppose when someone's possibly, I don't know, let's say they're either chronically depressed or become acutely depressed, or maybe there's both, they can have both of those two things, and perhaps it fluctuates. Yeah, I suppose if one was sensitive to a biologically like sort of reductive model, they could sort of lean on that. But actually, yeah, maybe like you said, there is, well, in fact, why suppose that there isn't always some sort of, given we are, meaning making and I don't mean that in some sort of kind of like purely like sort of idealistic kind of way. But why wouldn't there be a sort of a cause? Essentially, what I'm saying is, in some or some sort of thing, some factor which is underpinning it. And actually, I don't know if you're familiar with Mark Solms. Mark Solms is he's a sort of a neuro, I suppose what's called like a neuropsychoanalyst. So he's sort of tried to reticulate a kind of account, of Freud's ideas, sort of using sort of like neuropsychology. And it is actually, it's quite interesting. But he's anyway, being a psychoanalyst, he's also very skeptical and hesitant, and finds, I think he's actually said, basically, he didn't say I squirm, but sort of at the idea of psychiatric drugs, because essentially from a psychodynamic perspective, this idea of we have these needs, we have these drives, and we, you know, by our nature, we want to sort of, how do you satiate them, and at times we don't. And actually, and I wonder at times we also, even if one doesn't take a psychodynamic, or have a sympathy for it, I think we can still say, because I know some people like balk at the idea of the unconscious and stuff. It's like, don't be silly. I couldn't. I govern my mind. But regardless, I think, what do you think anyway? Do you think at times we overestimate, and maybe this is a scientific hubris we have in general. People probably find it in physics communities and stuff, in terms of being able to explain the universe. But what I mean, we're talking here about the universe per the mind. Do you think at times, maybe within psychiatry or mental health generally, we overestimate actually what we understand about the brain and its relationship to the mind?
Yes, completely. And I'm very skeptical about anything that claims to trace the neuroscientific basis of meaningful behaviors and utterances and states.
Mm,
Um, but I think there's a lot to be learned from the psychodynamic perspective. I wouldn't necessarily go along with all of it, but
mm.
I think the idea that our emotions are a signal that something is wrong in our life is a valuable one. When we feel sad, when we feel anxious, there's usually something wrong, and it may not be obvious to us immediately. It may take a bit of delving to work out what that is and what it is that needs to be changed. But I think seeing negative emotions or unwanted emotions as a signal that something needs changing is a useful way to approach them.
So there's okay, and so then what is your? I don't know if you have a message, or if you maybe you do, but you um, consider how you communicate it. I don't know, but I suppose there's two questions: your message to psychiatrists when you're communicating with them, and then also message to, I don't know, patients or people generally around. So I don't know if you want to start with when you're, or maybe I don't know if maybe they don't differ that much, but in terms of, say, when you're meeting a psychiatrist, if you were to meet a psychiatrist who said, right, I've got this patient, I'm considering, using. I mean, what is do you think? Because, and the reason I'm asking this, sorry, is because, and I know work in mental health as well, so one might say you shouldn't be so stereotypical, but I think there is psychiatrists predominantly do follow a medication model, right? So then if someone goes to a psychiatrist and what you're essentially saying is, hang on, let's just hold off a minute. Do we, or that's kind of the message I'm getting from you and your work is sort of like, don't just jump straight onto these things necessarily if you can. What is your message as to how to approach people at that point of where maybe they're considering it?
So, so first of all, I think we need to be very honest with people that there is no evidence that depression is a biological condition. Um, and there's certainly no evidence that the drugs that we have target any underlying biological process. And I think we need to be honest that the drugs actually modify the normal state of the brain in ways that we do not fully understand, and we don't fully understand what the consequences of that are. Um, so I think for that reason we should be much more cautious about prescribing. Um, and so I suppose that's my main message is just to get across because I think people have been muddled by this, by this pharmaceutical industry propaganda that's been going on for decades, and we need to get back to helping people to identify the causes of their low mood or anxiety and trying to tackle that, which of course isn't always easy. It may be, people may be in situations that they can't easily change. But even if they are, I'm still not convinced that just numbing people with drugs is achieves anything.
Mm,
Um, I wanted to say though, I think one of the reasons that we associate psychiatrists with prescribing is, I mean, when I was first training, I would say that psychiatrists had a more holistic role. And I think they've been sort of shoved into this rut of
mm.
prescribing, partly because, of course, they're expensive and have to justify um, uh, their activity with medical activities that other people can't do. Um, but I think it's a shame because when I was training, as I say, there was emphasis uh, on the biopsychosocial model, on a much more sort of holistic approach, uh, on bringing some sort of psychodynamic understanding to situations as well, and not just seeing ourselves as dispensers of medicine.
Yeah. And I wonder, what your thoughts are as well, because even I don't know, maybe some psychiatrists do offer extensive sort of psychological input, but actually, maybe even just that consideration that somebody going to a psychiatrist and just being able to sort of like the power of normalizing, the power of validating, you know, the containing of just being able to talk to someone and for the psychiatrist to go, yeah, it makes sense, you know, I'm not surprised, you know,
Mm.
actually how sort of powerful that can be.
Um, so yes, I think that's a really important thing that psychiatrists can do, and I'm sure some psychiatrists do. Um, if you're working in the NHS at the moment, as I do, you're probably aware that there are a lot of people who have already decided and been persuaded, maybe through TikTok or Instagram or wherever, that that they have a medical condition and they need a diagnostic label, and are quite resistant to that message, quite resistant to the idea that maybe what they're experiencing um, is a human reaction, is an understandable human reaction.
Mm,
So I think that message is sometimes quite difficult to convey, and I guess that's probably why there are some people, not just psychiatrists, but lots of other mental health workers who are going along with, this idea of, oh yes, you've got a medical condition, here's a antidepressant or some other sort of drug, because that's what
mm,
they feel is being demanded of them at the moment, and it is what many people are asking for.
yeah. Well, I'm mindful of the time. Um, yeah, that was great. I mean, yeah, we covered quite a lot there. Yeah, so yeah, your book comes out, I think the 16th of January. I'll, for those who've got to this point, I'll put the link in the description. So I know that it can be bought on Amazon. Um, I haven't pre-ordered it, but I will read it because I was able to read a very small snippet. I think through Google Books you can like read very small amounts.
Right, right, okay.
Yeah, and the yeah, it's good introduction, and you know, you sort of like courageously, you know, sort of share I don't know if you call it an anecdote of your own life, and then also of, you know, your colleague, and yeah, it seems to be written in a way, I think, for, you know, people who it's digestible for the perhaps I don't always like the term lay person, or but you know, someone who doesn't necessarily plow through academic papers will find it manageable and yeah, enjoyable.
Yes, good. I'm glad you thought that was certainly that was the intention. And the anecdotes you mentioned, so I describe my experience of being depressed as a teenager and compare it to the experience of a colleague of mine, um, separated by, I don't know, 10 or 15 years or something like that, and the different ways that we went because of the different ways that society has started to think about depression. And so I suppose part of the book is a plea for us to get back to a sort of intuitive understanding of depression, which saw it as a meaningful response to social circumstances that that could be addressed in one way or another, and not something that people just had to wait to find the right biological quick fix for.
Yeah, yeah, brilliant. Okay, well, thank you very much, Joanna.
Thank you, George. Nice to meet you. Nice to talk to you.
Yeah, yeah, likewise.
All the best with the
Oh,
podcast.
yeah, yeah, thank you, and yeah, take care.